So good afternoon, everybody from Physio TV. I am Rahul Chobe. I welcome the speaker and the panelist, and I am handing over this session to Dr. Fareen. Over to you, Dr. Fareen.
Thank you, sir. Good afternoon to all the viewers of Physio TV. I am Fareen Patel. Welcome you all to the webinar on Indian perspectives of women health by Dr. Bharati Bellare. Physio TV is a great platform for all the eminent physiotherapists from all over the world to share their experiences and knowledge. Today's honorable panelists are Dr. Nilima Bedekar, Dr. Aarti, Dr. Mithi. Dr. Bellare is our speaker for the day. Dr. Nilima Bedekar is the PhD from Pune University with 40 years of experience. She is currently working as professor and HOD at Sancheti College of Physiotherapy. She is a former member of Academic Council, and she is also research chairperson at UG BOS at MUHS Nasik. She is an expert in women's health, yoga, and electrotherapy. She has over 30 publications under her name in national and international journals. She has presented several national and international conferences, including WCPT Japan. Dr. Aarti is a PhD in women's health. She is a professor and HOD in OBS physiotherapy at Kahir Institute of Physiotherapy. She was awarded the Best Teacher in 2014. She has 32 national and international publications. She is a member of BOS Academic Council and editorial member of Indian Journal of Health Sciences. Dr. Mithi Raj is a women's health and continence physiotherapist with over 14 years of experience. She is a treasurer and on board of trustees for the Pelvic Obstetric Gynecological Physiotherapy, which is a national professional body. She is working as a specialist pelvic health physiotherapist at Chelsea and Westminster Hospital NHS Foundation Trust. I hand over the session to Mithi, ma'am.
Thank you, Fareen. I just would like to say that it is with great pleasure that I introduce to you Professor Dr. Bharati Bellare. She is a retired professor and head of Department of Physiotherapy at the LTM Medical College. She later worked as a professor at the MGM School of Physiotherapy, Kamorj, and during her 45 years of professional career, she has had the opportunity to serve as a president of the Indian Association of Physiotherapists. And she did this between the years 1998 and 2000. She has to her credit achievements which were first of their own kind in the country. When master's degree PT commenced at the Mumbai University, she served as one of the first 6 physiotherapy faculty members who were recognized as a postgraduate teacher and guide. She was the first physiotherapy professional to serve as the Associate Dean of 6 allied health faculties at the Kasturba Medical College, Mahi, currently known as Manipal University. She was the first Dean of Faculty of the Allied Health Maharashtra Health State University, which is MUHS, and she is also the first physiotherapist to have completed PhD studies under the Faculty of Medicine in India, 2003. She has had the opportunity to establish a 4-year professional degree program in PT, which is the BPTH upgraded from the BSc PT, and the first of its kind in the country. She single-handedly formulated the curriculum, including the syllabus, initially at Mahi in 1996, and then at the MUHS in 1998. This included subjects like PT in community health at the Mahi first, followed by a subject functional diagnosis at MUHS. She is the textbook of Prevention and Practice in Community Physiotherapy, volumes 1 and 2. And this was the first collaborative work of 3 medics and 21st eminent physiotherapists in the country. As an academic, her main focus was to upgrade physiotherapy education by establishing neglected specialties that have great potential. It was during this time that she began with physiotherapy in rehabilitation of hand conditions, followed by PT in cardiopulmonary conditions and clinical exercise physiology. Her last dream was to establish a women's health service, but it remains incomplete due to her retirement at the age of 65 years in 2015. So I would like to hand over to you, Dr. Bharati Bellare, Professor Dr. Bharati Bellare. Thank you.
Thank you, Miti. And first of all, I must be very thankful to the team for giving me an opportunity to speak here on women's health, Indian perspective. Maybe after talking to you, I realized that the scenario which I'm going to display today is not different in many countries, but I thought that it is mainly seen in our country. Anyway, so the physical therapy has grown very rapidly in India. Women's health has not picked up so much. It has remained neglected. Now, first of all, psychosocially sensitive issue of pelvic floor dysfunction is a major hazard in reporting about this problem, which is faced globally. But in our country, there are additional issues of gross ignorance among the general population. India includes a huge population of rural sector and economically lower section group, where the attitude of causing gender issues is tremendous. The females are depending on their husbands and the in-laws for their own health issues for treatment. Secondly, there's a very the self-neglect is taken as a pride. I'm sure all of you being mothers, and you must have observed your own mom eating at the end when everybody finishes eating. So this kind of self-neglect is already prevailing, which is preventing them from reporting when the problem is soluble, when it is in the early stage. And then there is a misconcept to accept the pelvic floor dysfunction, thinking that it's a natural consequence of parity and aging, and it has no solution. So these are certain misconceptions. And moreover, in the postnatal physical therapy is practically unknown even in the elite society. Here I would like to quote the statement given by Snigdha Mehta, who was a panelist last time. She said she's a very effective, very well-known physical therapist in women's health. She conducts a lot of antenatal classes, but the same clients are very reluctant to report during the postnatal physical therapy. We get very poor referrals from the doctors. What is the reason? Actually, it's a teamwork. What I understand, in the preliminary stage of women's health in the country, there are three members, main members, a gynecologist, a physical therapist, and a nurse. But the concept of interdisciplinary team work is yet to be established here. The physiotherapy services are available. Most of the work of pelvic floor exercise program is taken over by the others. And we have already done the survey on this, and we have got the evidence of very inadequate awareness about the scope of postnatal physical therapy among obstetricians. This is already it's published article. Now, who should take the responsibility when there is an ignorance among the normal population and the health professionals? It's a physiotherapist's job to create awareness about this novel profession. But then the question comes, are we ourselves neglecting the profession like this in this particular aspect? What is the reason? There are few cases which are very evident. Women's health is not reflected as an independent subject in the UG curriculum. Maybe the syllabus is very small, as it is very much unlike the other professions, like in medicine, Ayurveda, even in nursing. This occupies an independent subject status. There are hardly any master's degree programs in the country, though there are few in southern India. None of the other states have such kind of master's program, including MUHS. Women's health aspect in sports is totally overlooked. I had an opportunity to talk to a sports physiotherapist who is a foreign national, and I asked that person about the status. That person had no answer on this subject. So what is the reason for this? Is it a sustained confusion and there is a misconception that women's health limits only to obstetric gynecological conditions and focuses only on pelvic floor dysfunction? Here I would like to draw your attention This is a news which was flashed 2 days back in all the leading newspapers, in which one person called Ranjit Singh Disale, who won the international award of $1 million for his excellent work in the rural sector in children's education. What I would like to draw your attention is to his statement. I am a teacher of the 20th century who is teaching students of the 21st century with the syllabus that belongs to the 19th century and techniques of the 18th century. I start wondering after reading this, is this part applicable to women's health education, which is included in our curriculum? So is this lacuna in the women's health aspect is a basic problem why the physiotherapists are not thinking about developing their professional career in women's health. We know that in the absence of the central council, our curriculum is very much diversified. So probably few universities where the physical therapy program is going on, women's health part is elaborated. I don't quote them, but most of the areas in the country, this area is very, very neglected in education. I myself perceive that the word women's health is perfect because it widens the scope of specialty beyond the obstetrical and gynecological conditions. Because it does not deal with the female reproductive organs directly, but focuses on the obstetrics and gynecologically related movement dysfunction. And we are movement scientists. And this subject therefore demands for understanding management strategies based on the biomechanics and motor control of the entire abdominal capsule. I have fell in love with this word abdominal capsule. It may be not much familiar to others. What is abdominal capsule? It's a sac that contains the abdominopelvic viscera. This sac is partly bony and most of the part is flexible connective tissue. It has got three components. Its lateral part is called as the cylindrical support system. It has got a dome and it has got a sling. Now for physiotherapists, it is not just a container. We are interested in the skeletal muscles which are within this particular dome with a capsule. It's a diaphragm situated on top. Pelvic floor muscles, mainly the levator ani situated in the sling, and the core stabilizers situated in the cylindrical support system. And I would call these four muscles as the major contributory muscles of the abdominal capsule. Now, if you look at the coronal plane, the major muscles are seen here, but this is not the only contribution. Major muscles are having assistance from the other accessory muscles, which I would call them accessory muscles because, see, for example, few are quadratus lumborum, psoas major, rectus, then external internal oblique, erector spinae, etc., etc. All these muscles enable the major contributors to get attached in series. Lee et al. Have given the concept of cobra shape, where the diaphragm communicates with the levator ani via psoas major. Now see here, diaphragm is here, psoas major is joining the hip joint. Before that, it communicates with the obturator internus muscle, and through its fascia, the levator ani are connected. So this is like attaching the batteries in series. And all of us have studied in our 10th and 12th standard physics that when the batteries are attached in series, individual resistance can affect the problem of the others. So thus, these both the groups, major contributors and the accessory contributors, together form a unique kinetic chain. Now, what is the job of these muscles of the abdominal capsule? They squeeze this abdominal capsule and increase the intra-abdominal pressure. I will call intra-abdominal pressure as IIAP in my further presentation. Now, this increase in the intra-abdominal pressure is of great concern to us because of its adverse effects on the heart and pelvic floor. But are we aware that this IIAP is needed for a lot of vital functions, biomechanics of which is overlooked by us? Now, first of all, the skeletal function of postural control and lumbopelvic stabilization is very well understood among physios. But what about this other function, and that is a visceral function of evacuation performed by the skeletal muscles? This evacuation can be oronasal in the terms of vomiting, coughing, sneezing. Each maneuver is independent in its functioning. A second is pelvic, defecation, micturition, and parturition among women. Now remember, though there is only one physiological change of increase in the intra-abdominal pressure, The maneuvers which are performed for various functions are absolutely independent from each other. And with the result, each and every muscle which is situated in this group of muscles within the abdominal capsule is very, very function specific in contributing its own self for the various functions. And therefore, the motor control of the entire kinetic chain needs to be understood by physios. Now, for simplification, I would like to give you an example of this is an Odissi dance on Durga Devi performed by 8 dancers. Now, see, when the 8 dancers want to show an image of a single image of Durga Devi with multiple arms, see, only the main dancer is visible in one particular position, whereas rest of all the 7 have assumed independent positions behind her, and each and every person is holding the arms in the various directions. Exactly the same way the muscles work in the abdominal capsule, and need for a very, very unique coordination of the motor control. And when this coordination is disturbed, see what's happening. Few arms are jetting out of pelvic girdle. So this happens in case of the motor control of the kinetic chain of the abdominal capsule. That means the problem in the diaphragm or problem in the abdominal core muscles can affect the pelvic floor. So it's not the pelvic person may report with the pelvic floor dysfunction, but you may find out the local cause, abnormal behavior of diaphragm or the abdominal muscles. So we have to understand that they are all linked, and there are lots of evidences here which show that the muscles of the abdominal capsule communicate with each other and are responsible for pelvic floor dysfunction or vice versa. And this is how the term women's health is justified. It is not physical therapy in obstetrics and gynecology alone. It is a movement dysfunction which is related to that. So there is a need to highlight certain components in our professional education. That is what I perceive myself as an educator. Backache is a most common problem managed by physios. But look at the anatomy part. I studied anatomy 50 years ago, in which the total concentration was on the extremities, and the osteology of spine was very elaborate, but the myology about the muscles of the trunk was totally gone. Now, after insisting making changes in the syllabus, certain part is explained, but without any detailed anatomical structural point of view. Even in manual muscle testing, I have seen in many universities what I learned 50 years ago, the manual muscle testing of flexors and extensors of the spine as muscle power 1, 2, 3, 4, 5 is still going on. Whereas lumbar stabilization is already understood by the people, but the biomechanics behind is inadequate. So in the final year when they study, they are unable to give the reason. The result is inadequate understanding about the kinetics of the abdominal capsule muscles and motor control during various maneuvers related to IIAP. And the candidates do learn the skills of lumbar stabilization, but if you ask them, you explain the biomechanics, they will not give adequate clinical reasoning. Why? Because in basic understanding, in basic anatomy, the natural lumbar corset, which is provided by the support system of the AC, is not elaborated. This is a cross section of the natural lumbar corset, which is shown to have incorporated the 3 components of dorsal lumbar fascia, then the muscles here, the rectus, and then rectus sheath, the crossing fibers, and the linea alba. And specifically, the role of linea alba is to serve as an anterior zip lock. So when the linea alba is deficient, obviously it is going to have an adverse effect on the stability of the lumbar spine. And that's the reason we have to take into account the diastasis recti related issue. But I really wonder how many people, how many physios look for the presence of diastasis recti when they are examining a patient having low back pain. So this aspect has to be inculcated in an undergraduate student itself before they take the further program. Next is the structure of the anterolateral abdominal muscles. Look at the pink part, which is represented by the contractile tissue, and the white part, which is represented by the aponeurosis, the flattened tendon. See, transverse abdominis doesn't look like a muscle at all. Very small portion covered by contractile tissue. The rest is all aponeurosis. So obviously, a non-contractile structure, when subjected to repeated IIAP, they are definitely going to get overstretched, like an overstretched rubber band, and develop a lag. But how many of us take into account the mechanical lag of the abdominal wall muscles, which is mistaken as muscle weakness, whereas we are well aware of the mechanical lag of extensor lag of the quadriceps muscle, extensor lag of the finger extensors, but lag of the abdominal muscles is hardly taken into account. Please correct me. Maybe I'm an old chip, so maybe I'm not well versed with the latest methods which are given now in the last 5 years. Same thing happens to the biomechanics of diaphragm, where everything is focused on the breathing mechanism. But what about the two crura, the left and the right crura of the diaphragm, which is attached to the lumbar spine and are responsible for determining the curvature of lumbar spine? Now here I would like to draw your attention to a woman performing Kapalbhati in sitting position. See how she is sitting. Even if you sit erect, it's not enough. You have to retract both the shoulders. Now I request all the listeners to just sit erect and then retract your shoulders, and you will see that your lumbar spine lordosis increases. It is a function of these two crura, which is never taken into account. And therefore, we are unable to reason out as to why reduced lumbar curvature imposes risk of pelvic floor dysfunction. Now see the lumbar curve, which is determined by the proper lumbar lordosis, is determining the inclination of the pelvic floor. See, when there is a proper lumbar lordosis with proper anterior tilt of the pelvis, the coccyx is always above the level of the pubic symphysis so that the pelvic floor remains inclined. So in such situation, when the IIAP develops, its vectors fall on all the bony prominences like sacral promontory, pubic symphysis, and go back to the coccyx, and the pelvic floor is spared. Whereas when there is a pelvic posterior tilt, or when the lumbar lordosis is flattened, all these vectors directly fall on the pelvic floor. And that's the reason whenever a woman reports about the stress urinary incontinence, she has such episodes more while sitting and squatting than in standing. So the postural support has got an impact on the pelvic floor function. And the risk of late onset pelvic floor dysfunction is also known. Now here I would like to draw your attention. If I ask a question to anybody, what happens to the lumbar lordosis during pregnancy? Most of the time the answer is lumbar curvature increases during pregnancy. We did the survey and we found that it is not so. In fact, the lumbar curvature flattens. We did the study further and found out that the pregnancy associates with the increased posterior tilt of the pelvis, and with the result, the curvature, the lumbar curvature appears to be flat. And if the same situation is sustained postnatally because of the bruised pelvis, bruised pelvic, the pelvic floor, and the episiotomy scar, if it is painful, the woman is very apprehensive. She holds both the perineal area tightly, which is called as butt creeping strategy, which pulls the pelvis down and attains a posterior pelvic tilt position and causes this. And this kind of people, ladies, will develop pelvic floor dysfunction in the later stage, not immediately after the delivery. This we need to understand. So therefore, addressing each and every affected component of the abdominal capsule is mandatory in the management of pelvic floor dysfunction, which needs to be inculcated in the students, even at the undergraduate level at all. Whereas management of the pelvic floor dysfunction is included in our undergraduate curriculum, but its detailed anatomy and biomechanics of pelvic floor is not highlighted. We know that the pelvic urogenital hiatus has got a very highly potential hernial portal. And moreover, bipedal woman, the sling is practically down, so it is at much more risk than the quadrupedal animals. Generally, pelvic floor is considered as a hammock, but I will call it as a trampoline, because the trampoline is tightly stretched and it can withstand the caudal impact of the IIAP and the ground force reaction, which is seen in people in sports. And any sagging of this pelvic trampoline will fail to withstand the stress and cause dysfunction. Pelvic fascia, the details of the structural conditions is not elaborated in our anatomy. See, this pelvic fascia is containing 3 storing organs, the rectum, the uterus, and the bladder. And when they are storing, they have to expand. And for that purpose, there are lots of hollows provided within the pelvic fascia, which makes it very, very vulnerable. And therefore, the role of pelvic floor muscles to support this and suspend all the load is a very, very important factor. And that is how the pelvic floor muscles, though they are very tiny, they play a very major role in supporting the pelvic organs. If you look at the motor control of the continence, levator ani are the only muscles, active muscles, skeletal muscles, which are active throughout 24 hours, even during rest, and they contract via straining levator reflex against the IIAP. Whereas there is an evidence that chronic impact of IIPP, due to various reasons, it should not be ignored, and in fact, it is likely to cause an adverse effect on the protective reflex and jeopardize the mechanism. Here I would like to draw your attention to our survey on few veteran yoga teachers. They were teaching yoga, all females. We did a study on transabdominal ultrasound study on the on the bladder neck mobility, and we found that while performing Bhastrika and Kapalbhati maneuvers, the bladder neck mobility was drastically high. But when we asked them to apply Mulabandha, this Mulabandha acted as a preventive measure. We wondered, because in Bhastrika is a part of pranayama. In pranayama, yoga strongly recommends application of Mulabandha, but the concept is different. In yoga, they say that during pranayama, you are trying to build up the prana energy, but the prana energy is likely to get leaked out through Muladhara Chakra. So therefore, application of Mulabandha is strongly recommended. But ladies, while performing that, they avoid applying Mulabandha because they feel that by drawing their attention towards the Mulabandha application, they are distracting their mind from concentrating in breathing. And therefore, when I asked this question, none of the females said that they were applying Mulabandha. Whereas in our study, Mulabandha functioned as a protective maneuver from biomechanical point of view. Whereas Kapalbhati is a Shuddhi Kriya. So application of Mulabandha is not recommended at all. But then we felt that Mulabandha application specifically in vulnerable women is very, very essential, because among them, those who were married with parity, they had more risk factors. Their mobility was much, much more. And this particular article is already published in the International Journal of Yoga. Next thing is, to offer continence, the pelvic floor muscle must contract before the development of IIAP. That means, if you take an example of those Odissi dancers, if the last candidate stands up first and then the first lady stands up, what's going to happen? Same thing happens here. If there is incoordination caused by a premature contraction of other muscles of the abdominal capsule before the pelvic floor muscle contracts, the accident may occur. And in such cases, pelvic floor muscles are many times healthy, and still the accident occurs. Speed training, lapses. This is one of the most favorite activity in sports at those who are trying to build up their tone and from aesthetic point of view among ladies. But this kind of activity is likely to cause overstrengthening of the global abdominal muscles, the speed of contraction, superspeeds, the contraction of the pelvic floor muscles, and the accidents may occur. Similarly, those who have the chest gripping attitude, ladies with bulky abdominal wall, they always keep their abdominal wall flattened by sustained contraction of the global muscles, also are susceptible for accidents because of the affection of the motor control. So one has to remember this issue very well. During our study on yoga females, yoga experts, we had found that 4 of them were involved in power yoga, and none of them could isolate the transverse abdominis contraction because the contraction of global muscles was so quick. And mind you, out of 4, 3 were Paras ladies, and everybody was suffering from stress urinary incontinence. And none of them was using Mulabandha while practicing pranayama. Unlike the entry-level education in other health professions, I have already said, women's health is included under a short subhead of the other clinical subjects. In other states, probably this subject is added under the main subject in cardiopulmonary physical therapy. But in MUHS, it was added in community physical therapy, where prevention aspect is to be highlighted. But prevention aspect of women's health is not found to be highlighted to that extent. Whereas The restorative and rehabilitative aspect of pelvic floor dysfunction is included without any inclusion of correct assessment method of the pelvic floor. Now, we all physios know that manual muscle testing is a very important assessment tool for the muscle education. But unless and until we understand the status of the muscle, we cannot educate. But we expect the student to give pelvic floor exercises without knowing the muscle status. I know that this particular aspect, it needs palpation method, which has got a lot of social and legal aspects. Many people are also apprehensive in adopting this. But then I would like to ask a question. If you want the candidate to give pelvic floor re-education exercises to a person without doing any examination or without knowing the actual status of the muscle power, can we do justice to rehabilitation? Then how are we different than the other professionals who use a standard protocol of Kegel's exercises and claim to be experts in this? We cannot fight in that matter. We are no different than that. And that's the reason my main intention was to suggest that palpation method should be included, at least during internship. Some the teachers had argued, they said, we tell our students to observe the perineal contraction when they are training the pelvic floor muscles. But perineal contraction is performed by superficial perineal muscles. Where are the levator ani? Superficial perineal muscles may be normal, or they may be healthy, they may be overactive also, without knowing what is the status of the levator ani, which are situated deep. Therefore, because this concept is prevailing, the concept of hyperactive or rather hypertonic pelvic floor muscles related issues are practically unknown in this country. Nobody reports, nobody treats. Very, very few. I heard only one person who has come from abroad has started such kind of practice. We should find out the difference between what the doctor does while doing this palpation examination. The doctor will look at the structural changes from surgical point of view, whereas a physio will feel the functional changes also from point of view of qualitative and quantitative assessment. And accordingly, she will plan the future program. Now we know that we have to do separate assessment of superficial and deep muscles of the pelvic floor for the rehabilitation purpose. And we have to attain a skill to identify and treat the trigger points, if any, and which must be included in our postgraduate program. If it is going to start now, I'm very hopeful that it will start in future. And then we have to even explain to the doctors why this is needed, because we do pelvic floor examination in 3 ways. We are not just restricting ourselves in passive testing by just testing the tone, but we also ask the person to cough and check the reflex contraction of the pelvic floor muscles, because many times in spite of instructions, the female is unable to understand what is the correct contraction. So during this process, we are likely to get, if there is an early prolapse, when there is an impact during cough, if the impact is falling on the dorsum of the fingers, you may conclude it as a cystocele. If it is on the tip, it may be uterine, or if it is on the basal, on the volar aspect, it may be rectocele. In the early stages where it is not visible from outside. Then we ask the person to do active contraction for qualitative study to find out the squeeze, whether it is even on left and right side, whether there is a proper posterior bulk, whether there is a cephalad lift, whether the contraction is quick or it is sluggish, or the ability to relax is quick or slow. All these aspects are needed to be understood by a physio. I'm sure such kind of examination is not by the other health professionals, because their concepts are different, their domains are different. And of course, we do active contraction assessment by quantitative study to find out strength, endurance, and fatigue, which is definitely there, but the other aspects are also necessary. We may even ask the persons to strain to identify early prolapse. One more thing, accessibility towards use of real-time ultrasound is available all over the world, globally. All the physios have a free access to this machine, but we physios in India are banned from using it because of the Supreme Court order. All of you know the reason behind it. So with the result, we are unable to use this equipment, which is very, very useful in the rehabilitation of pelvic floor. Whereas, if at all you want to do the study, we have to depend upon the radiologist, and most of the radiologists are busy in their own clinical work, and they hardly use M mode. So it is very, very difficult to use this equipment for our purpose of research. Whereas the computerized periometer, though it was available, People are not using it properly. It is underused. This was told to me by one of the suppliers. In fact, I did my doctoral study way back in the year 1996, where I procured this equipment for my personal use from abroad, and it gave me a full package within one unit, where in addition to assessing the top, the peak amplitude and the average amplitude, it also provided me the perimeter of gradient. See the difference how the parous female and the nulliparous female's gradient. It is the ability to contract quickly, the speed of contraction, which is a very important parameter when you are assessing a lady with problem of frequency in coordination, frequency. It also gives you the fatigue development, because the pelvic floor muscles, the levator and I contain 60 to 70% of the red fibers, slow conducting red fibers. So they are in majority contracting, but the way they go into fatigue, the fast fibers come into picture, and you can see this fatigability developing within the muscles. All these parameters are of great use when you want to implement them, depending upon the person's functional diagnosis point of view. But I was told that since this equipment was not used by the people in India, now this equipment is not sold in India with the package within it, but all the packages are now converted into software, which is supposed to be purchased separately. And most of the people, most of the teachers or the faculty members or clinicians use this pereniometer mainly for rehabilitation point of view or for the biofeedback. So now I would like to point out certain things of suggestion. Because this subject is added under community physiotherapy, we need to highlight certain preventive strategies in women's health. They are in primary prevention, where the population is healthy, but the risk factor is hidden. So we have to teach them the good habits right from their childhood. It should be taught. Education on bladder and bowel habits. Then we have to teach them to differentiate between the urge and the urgency. Urge is to void small amounts when the bladder is not full, whereas the urgency is to void when the bladder is full. This differentiation should be appreciated. Then the question comes, is it bad to hold the pee? Not at all, till the urgency is felt. But what about defecation? Urge to defecate should never be suppressed. This should be told to the children, because they are the ones who are likely to be ignoring the urge, because they are very playful, in that playful mood. So we have to concentrate on good dietary habits, adequate intake of liquid, activity limit, the activity inducing games and not the video games. In this pandemic, you must have seen our children are addicted to such kind of games in the sedentary status, which should never be encouraged in otherwise. Then regular bowel movements should be taught to a child when he is in the early age. And those children who are going to school, the parents must make it a point to go and visit the toilets. If they are dirty, then the child is not going to use and going to get constipated, or they will avoid passing for voiding mechanism. You have to teach them proper positioning during defecation. Now, squatting is an ideal position for defecation because the perineum is stretched out and with the adequate descent of the anal sphincter, which is necessary for defecation process. But one needs to have a proper straight back for the optimum activity of the lower rectus muscle. Crouch position is not recommended. You have to sit erect and squat. But whereas in the Western culture, we are used to commode system. In this sitting, 90 degrees of hip flexion, person has to make more efforts, and therefore the straining, the downward impact of IIAP is always more. So in such situation, to simulate the squatting position, it is always recommended to use a small stool under the foot so that it simulates the activity and person is able to defecate properly. We also need to give advanced education for prevention of obesity in women during various vulnerable stages. Stage 1 is during growth. Stage 2, during puberty. There is a sudden rise in weight gain. The next is during reproductive age, when the family planning is adopted by taking either pills or tubectomy, and they are actually disturbing the normal balance of estrogen levels. And obviously during climacteric, where the estrogen balance is disturbed because of aging issues. So you have to give them advanced education so that they can take care of the obesity related population. Now, secondary prevention is when the risk factors are emerged, but the subject is not symptomatic. In this case, the sources of chronic exposure to IAP should be identified, like high impact activity, weight reduction by skipping. Ladies who are involved in heavy labor jobs, carry heavy loads, those who have chronic constipation, chronic cough, or those who are involved in high impact sports where the ground force reaction is tremendous, where you cannot avoid IAP, they should be taught splinting and knack maneuvers for the compensatory activity to withstand the IAP as far as possible. In this, I think there is a lot of research needed to be done. In India, of course, sports, the women in sports, it's a totally virgin area. So there is a lot of scope for the youngsters to take this as a challenge. Antenatal stage. Pregnancy and labor and delivery are not pathological, it is physiological, but tremendous physiological load. So antenatal exercise program is picking up, but it is so much overlapped that many non-professionals who are not physiotherapists are indulged into doing this. It was when I heard about one news that the College of Physiotherapy had invited an occupational therapist to teach antenatal exercises. I was terribly hurt. Third is tertiary prevention. When the person is already affected and you have to handle the case, in which there is one stage which is called as early intervention, where the condition in which certain natural reversibility is likely in spite of not taking treatment, but our intervention will definitely hasten up the recovery. Then there is the second category of long term, where there is a coping strategies which are to be implemented to prevent the morbidity. Now, in this aspect, at MGM College of Physical Therapy, my interns, my fourth year, final year students had conducted a survey on 350 postnatal primiparous women within the 1 year of postnatal status. And when they brought their children for immunization, they were anyway there. So we caught hold of them and the survey was conducted. And we found that there was 25% incidence of stress urinary incontinence, 5% incidence of prolapse, and 65% incidence of sustained diastasis recti, which significantly correlated with their associated low back pain. So this indicates that why it is happening, because maternal care in India is mostly privatized. Even when the government of India runs maternal care services, it is limited to very few rural areas where physiotherapy is not reflected at all. So we have to take a note of it. And since there is no council, there is nobody to recommend to the government of India to include physical therapy in maternal health. Puerperium is an ideal period of early intervention because the first 6 weeks after delivery, there's a strong hormonal backing for the reversibility, in which there are two methods of training. One is technocentric approach and one is ethnokinship. Now, in the technocentric approach, which is adopted by the Western population, where the woman is expected to join back her routine work within 3 to 4 days. And then she has to do all these activities, exercises which are taught along with handling the baby. Whereas in ethnokinship, it is totally based on our traditions. And India is very much blessed with excellent ethnokinship, where the mother is actually pampered. That baby is taken care by the caretakers, mother is given adequate rest. But what is a major barrier in implementing physical therapy, the technocentric approach within this ethnokinship, is there is a total taboo on performing any exercise, which we conducted. Ashwini Kale, who was my PhD student, who was awarded PhD degree very recently, her thesis was cultural impact on the postnatal physical therapy intervention and effect of culturally suitable PNP, in which we found that there was a lack of awareness about the scope of physical therapy, of course, and the traditions and beliefs were so strong that there was a significant negative impact on the postnatal physical therapy intervention. Exercises were not permissible. So we had to adopt it, which was a culturally suitable program, and we found highly positive attitude after educating the ladies and a significantly positive outcome of various parameters during the postnatal stage, where the follow-up was conducted till 3 months. All the 135 females who were studied were from the rural sector and from the lower economical group. And we were pleasantly surprised to see their very, very positive attitude and consent and the compliance when we implemented this culturally suitable program on them. One more thing I would like to suggest, many women, when they are on the long travel, they have a habit of evacuating their bladder and bowel in a partially squatted position. Because when they visit the public toilets, the toilet seats are very dirty or they are unable to squat down in the Indian toilet. Now in this case, you see the mechanism. Now here, the coccygeus and the pubococcygeus muscle, they form actually the seat, the rather the shelf for carrying the load of the organs. But look at their ankles. Their anchors are piriformis and obturator internus muscle, which are actually attached to the hip joint. So when they stretch this trampoline further and you perform IIAP against the stretched trampoline, you can imagine what must be happening to it. And I was quite shocked when I saw a delivery being conducted in one rural sector, where in the labor room, there was nothing but a small hanger on top. And the lady was holding the handle with her hands, and she partially squatted and strained during labor. You can imagine what kind of accidents which are likely in this position. But it happens in our rural sector even today. So we have to educate them to avoid partial squatting position during pelvic evacuation. And we have to give them proper ergonomic advice. See now this first picture, the way the perineum is so much stretched. If she coughs or sneezes violently, and if she's a vulnerable stage, what is going to happen? Same thing here when they're performing their day-to-day activity. So we have to tell them actually how to sustain their position, keeping both the knees together. When she's grinding on the grinding stone, which is very heavy and strenuous job, she has been asked to adduct her knee so that the heel of the foot is at least very passively giving a counter pressure to the perineum. So therefore, we have to also tell them not to ignore the chronic cough, constipation, vomiting, and they should immediately report about it to the doctors, because these are the areas which they are likely to neglect because of the prevailing attitude of self-neglect. Then in the long-term tertiary management, graceful aging, we have to concentrate on coping abilities and avoid the urge to cope, urge to defecate. We see that when these ladies are traveling, they have a habit of visiting toilets wherever they are available. And even if the bladder is not full, just in case if it is not available, that anxiety forces them to use the toilet, and they avoid small quantities. And this long-term habit can reduce the bladder capacity, which is non-reversible. Some of them use sanitary napkins fine, but when they adopt not to drink fluids during long distance travel, which is not advisable. So what you should do is teach them various methods to coping and try to differentiate between urgency and urge. Now, of course, hyperactive pelvic floor muscles, I do not want to discuss because it is not at all known in India, though we must have heard the terminologies. So how can we solve the problem in our educational pattern? And that is by overcoming the barriers and promoting education. Now, in this aspect, I would like to give certain suggestions. You understand the gender issues and attitudes of our women, and try to take into account what is their need. Now, the last picture, this where the women are involved in planting the saplings of rice. So with these, they adopt this position for hours together. Obviously, they're going to have a high prevalence of low back pain. I visited this particular rural area, tribal area in Gadchiroli, and there a physio who was appointed was frustrated. She said, nobody is paying attention to me when I tell them to take rest in between, because they are not interested. The number of saplings is going to give them they're going to decide about their wages. So you have to plan for culturally suitable intervention, taking into account their activities and based on the functional diagnosis. So in community education, always include those groups which are formed exclusively by women so that you can have heart-to-heart talk to them. Always target the Mahila Mandals religious. These are Jain Mahila Mandals, or these are probably Muslim. So the religious Mahila Mandals have plenty to tackle. So you can catch hold of them. You can even go and visit the sports complexes where exclusively girls are trained. Or you can visit the institutions exclusively for girls and educate them in advance about the risk factors and how to cope up with the situation. Then awareness among the team members. Now, just now, Miti told me before the session started that they deal with the issues where the doctors themselves are not not just limited to the gynecologist alone. There are dermatologists, there is urogynecologists, there are various other medical professionals. But here in India, we are still in the basic phase. I would consider a doctor, a physio, and a nurse as three main team members of women's health. And in which, if you educate them properly, it enables differentiation between the inter and transdisciplinary approach, so that the co-partnership can help to establish our professional identity. So how will you impress upon them and say that you are different than them? So basically, how are you going to be different in training the pelvic floor muscles than them? So here, when the same issue I had to discuss with my medical colleagues, I prepared a theoretical model and explained to them. I said, if there are three ladies having stress urinary incontinence, one lady complains that she leaks after walking with a load for some time. Other lady says she leaks when she laughs very violently. And third lady says when there's a leap, she has to kick somebody or she has to take a leap she wants. Is a common protocol of Kegel exercise going to work? When I asked these questions to them, there was no answer. So then I said, we physios have to do the analysis. Now this lady says, sorry, what's happening? Sorry, there is some interruption. So this lady says that she leaks, so that is a sustained loading which is challenging her red fibers. And we know that the levator ani contain almost 70% of red fibers within. So it is a challenge for training the red fibers. This is a challenge for white fibers. I think there is something wrong with this slide. So we have to take into account that it is a job of white fibers. So they are fast conducting high intensity fibers. And the third one, it is purely a coordination. So they have to give different kinds of protocols. They are to be used for training the pelvic floor muscles. So this is how physical therapist is different than the others. And that is why we insist upon individual need-based exercises as per the functional diagnosis. Now, when we have to impress upon the medicos for the reference in the post-surgical cases, when they perform the surgery on pelvic floor, pelvic surgeries, we have to give them this Delancey's concept is an excellent model where it is a model of boat in the dock. Many of you must have seen it, where the boat is the pelvic organs represent as boat, levator ani as water, and pelvic fascia and its link as the moor. When the levator ani are weak, the whole burden falls on the rope, on the pelvic fascia and its links, and it is likely to break. Now, in this situation, even if a doctor performs a surgery and reinforces the linkages, if the levator ani are sustaining as weak, then what's going to happen? The risk is still continued. It is likely to break again. And the ideal example is prolapse of the vaginal wall following hysterectomy performed for the prolapse of the uterus. Why does this happen after the uterus is removed? Now, these are the concepts which will definitely help them to understand how we are different than them. So I would like to, at the end, I would like to draw your attention to the last reference in which the author says that the physical therapy intervention for pelvic floor rehabilitation should be a combination of physical, cognitive, and behavioral together. Now, what is cognitive? That is going to be dealing with the beliefs, traditions, acceptance of disability, and avoid reporting, etc., etc. What is the solution? Create awareness. Next is behavioral, self-neglect, frequent voiding and avoiding fluid intake as seen in the elderly females. Create education and acceptance of healthy lifestyle. And last is a physical, in which you have to consider the culturally suitable and individual need-based supervised training and include the coping strategy methods. So thus, at the end, women's health is far away for succeeding as a professional activity. So therefore, the path which is so difficult and having a lot of hurdles because of cultural barriers, attitude, and ignorance, what is my suggestion is the physiotherapist should wake up and perceive our own ignorance, acquire knowledge about the cultural impacts and everything, produce professional reforms, and get over the prevailing barriers, build up the skills which are cognitive, behavioral, and physical. Then you proceed towards creating awareness, and in such a way that you make them understand so that they will achieve, you will achieve their acceptance, commitment, and compliance. Then you explore the opportunities very carefully. I have seen physios getting drifted towards the lactation counseling, which is not our domain basically. It is somebody else's domain. Why should we explore those areas? Instead, you enter into the hyperactive pelvic floor muscle management and certain activities which are the leakage of urine during sexual activity, where we have a very small role to play, of course. And when you get over all this and you proceed further and get over all the problems which are already preceding, only then you will be able to reach the peak of success and change the Indian perspective in women's health. Thank you.
Thank you so much, Bellare ma'am. That was indeed a wonderful session. I would like to request the panelists to open the session for question and answer.
Yeah. Can I start?
Yes.
Am I audible?
Yes.
Yes, I can hear you.
Yes. Madam, thank you so much for bringing in the biomechanics part, which is missing so many times in all these lectures. And their connection to the bone, the capsule, abdominal capsule, it's amazing. And especially the ethnokinship. I think the cultural aspects we have to really further explore. There are so many good things that you have been explaining, and you've been working so much in this field. And the idea of this behavioral model, I feel these things have been highlighted so well that, this time is not enough to, understand all these concepts, but you have covered so much. I don't think any question is there from my side, but to appreciate more and more. So yeah, that's from me.
I think Meedi will have some questions because she's working in a different setup abroad.
Yes.
Hello, hi. Can you hear me?
Yes, I can hear you.
Okay, great. Well, firstly, thank you so much. And as Nindama ma'am said as well, it's so important to not just think of this as, oh, do your pelvic floor exercises, but kind of looking at the patient as a whole. So I think it was really good that you spoke about like the functional and the fascial connections of the pelvic floor and how that interlinks, because it is so important that when you're treating the patient, you're not just prescribing them pelvic floor exercises, off you go, as you very sort of correctly mentioned about sort of, the practices that is there, just observe the superficial fibers, and that is in my opinion as well not the correct way of doing it. So my question is just more about kind of the practices in terms of like, how does this clinically translate to when you are practicing in the sort of, in clinics in India, in terms of certainly, as you said, about the awareness and perhaps even the lack of understanding within the community, the medics and the physios, etc. But also in terms of with the patient population as well, do you have patients coming up to you with these concerns, and also what's the compliance like, and what's the patient mentality and acceptance of all of this?
Now, in my career, when I was pursuing my PhD program 25 years ago, that time, of course, the reporting was not there at all. But while during my own assessment, I had come across few cases, and I tried my own methods and succeeded in a couple of cases. But it was not an evidence, I can say. And I could not authentically say that it works, because those days, even the concept was not, the evidence was not available even in the literature. Today, the literature shows a lot of evidence on mobilization of the trigger points and all, which was not there at that time. And I don't think anybody is reporting. I question many of my medical colleagues, the gynec obstetricians, and what they say is there is a very limited reporting about that. And they use some painkiller medicines or sometimes some kind of injections and all, but they never refer the cases to physio. And I will never blame any other health professionals. I will always blame our own professionals for neglecting the area, because it is a responsibility of physiotherapists to create awareness among them. Unless and until you develop a proper team, it will not work with efficiency. I have seen wherever I went, and I had a team of nurses and doctors. We had very good teamwork. In fact, my guide was a gynecologist who refused to accept me to work for PhD under him. But when I convinced him what is my domain and what I would like to do, in fact, he told me, Madam, I don't understand anything about physical therapy. I will only give you patients. You do your own study. So for the name's sake, he said, I will only serve as your supervisor by referring you normal cases. See, patients for pelvic floor exercises who are healthy, it has a lot of legal applications. But since they were coming to him to attend the infertility clinic and understanding the behavior of the pelvic floor muscles from point
So
of
I
view
think,
estrogen
madam,
levels, he
yeah,
gave me this and I studied on my own. It was sort of self-study. So there were a lot of limitations in understanding the advances, which I'm sure you people must have come across today.
right. So, madam, do you give a message that really we physiotherapists have a onus to get this
Yes,
forward?
very much.
And yeah, so
Yes,
like
yes,
we
yes.
don't get we send our interns or PGs, to get the appointments, but even getting appointments, so we have really lacked. And you as being a pioneer, still
Because
I
they
feel,
feel who see. Exactly. This Kegels exercises are well-known activity, but can it work in each and every case? And in fact, when we during our survey, we asked these questions to these medical practitioners. Half of our questionnaire was left empty. It was not filled in. They didn't want to commit that they are ignorant about it because they see that there is no success because they don't look at the patient like how the way the physio has to look.
I feel the education now, our education also should not be
Needs to
lacking,
be
isn't it? So we should generate the students who are equipped with doing,
yes,
these
yes.
assessments, and then
So I
only we
request
will be
you,
able to.
Nilima, you are in the board of studies. Please take this into account and make the changes accordingly.
Yes.
Yeah, I'll ensure. Yeah, I was there, but I am still, being affiliated to it. I'm not on the US, but yes, I have expressed all my views and will take it further, I feel, because educating appropriately and training with those skills is still
Yes.
lacking somewhere. I feel that's why it still needs to be incorporated really with great empowering our students, to make
Yes.
them do it really will skillfully. Otherwise, women also don't come to the next session at times. We have observed that. So to gain their confidence, our students should be, supported and trained and skilled. So I really am impressed at how much efforts we have been taking. So further we have to carry on, and now I feel the next generation of teachers have to take it further.
What about
Aarti, madam.
Aarti? Aarti
Yeah,
is a young.
ma'am. Yes, ma'am. Ma'am, definitely you are, mother of women's health. So I would not like to ask any questions because you are the one who have a very gross knowledge about everything. Maybe a little untouched about the recent advances, but that's fine. But I was very happy to see your researches where you have created our own databases of Indian females. Otherwise, when we did our PhD, I had references of low back pain from all Western countries. And that is how it triggered my mind after my PhD that we started screening different types of pelvic pain, like anterior, posterior, or vertical and horizontal. And we categorized it for try to find out the prevalence rates. We have also added on to the databases. So what I feel is if we are taking up researches along with the gynecologist, one thing is they are very busy to conduct researches, and they will be having an advantage that they are included into a study, plus we will get patients and awareness is created. I would also feel good because I have tried to publish articles that we have done in most of the urogynecology journals, so that those people read and they are better coming up with the knowledge what we are doing rather than we publishing it in our own journals.
Now,
So
in
I
this
would,
aspect, I would like to actually, I don't know whether it is right on my part. When we
yeah,
wanted to publish that article, which I mentioned about
yes,
the awareness among obstetricians, when my article was sent to the Indian Journal of Obstetrics and Gynecology, it was point blankly rejected.
uh,
The answer
oh,
was, we know what is postnatal physical therapy. They did not find any problem in it, though there was a data which gave an evidence that there is an inadequate understanding. And about 96% of the gynecologists agreed that the referral
didn't
system
know.
for postnatal physical therapy is very poor in the country. Yet the article was rejected. Then we published it in a different journal, which is a physiotherapy journal, because I knew that it was sort of offending them. So it was not right on our part to send the journal article to any obstetrics and gynecology journal. So we published it in a physical therapy journal.
No, the same thing happened when I had submitted 2 articles to the journals of obs and gyn. But then later on, I had a smart thing. What I did is I included the OBG person as one of the co-guides of our students and our project.
Then they agreed. Okay, yes, I should have done that.
And those smartly selected where they were the board members of those journals, So most of the South Asian Federation of Obs and Gyns, my articles are published. So that way, our evidences are created well. And I would, ma'am, as you in your, I think, 5th or 6th slide, you gave a list of all the references and they all were Western where they have done, interventional studies. So I'm not saying that we should not do, observational. Observational is definitely needed to create databases of our cultural impact on pelvic health.
Very much. Yes,
but interventional studies are very important so that, even Western cultural people start reporting that our cultural habits and conditions are totally different according to their cultural behavior.
Requirements are totally
different. Requirements and therapy also will vary according to our ethnicity. So as you, and I really loved your slides that you have given, beautiful connection with those dancers and how the capsule is working. I mean, even at this level where we are, into that profession for more than 10 years, I just loved to see those slides in a different way. So, ma'am, I'm very happy to hear you again and again. So no questions from my side, but I would definitely tell all the participants who are attending this that it is, again, as madam said, our responsibility. If we want someone to pull us, that's not possible. We'll have to go and spread our hands, to accept it. Maybe over time, definitely, because when I started, hardly any gynecologist referred, but now it is a teamwork. We are compulsorily have to see all the postnatal cases in our hospital. Definitely perinatal is getting a little difficult because I know it's a kind of, when we try to get normal deliveries, they may not feel it good because sections are favoring their earnings.
Such cases may develop some issues later. So if you make them understand that these are possibilities, we were so happy to see women coming from absolute rural sector, illiterate women. They used to travel in a bus and come for the follow-up. Once we convinced them about all the possible things, even their husbands, their family members were cooperative. We have to take them into confidence and tell them the consequences. If they know about the consequences, they will definitely come and attend.
Yes, ma'am. Yes, ma'am. So awareness.
Yes,
awareness should start from
culture,
school, I feel.
Yes.
So
in
school
UK,
we are targeting.
Yes. Yes, Aarti, you said something?
Yeah. No, what we tried to, develop awareness, like every Saturday we used to go to schools where especially girls batches are, separated, and we try to give awareness about what organs we have, what all they'll be taxed with in the future course of our life. And we have done a lot on even sexual dysfunctions in our own nurses. And these were the nurses who started referring the patients as well. So we conducted a lot of camps and studies. So community was one we targeted, and references directly started coming to us. So it's not only associated with the obs and gyn people. And though we don't have a separate male pelvic health clinic, so we are treating the male health pelvic health issues as well.
See, my subject was mainly related to women's health, and let me tell, I have not done anything for males.
Now, when the urologist referred, but when a urologist referred 4 or 5 cases of male incontinence, I could not say no because that was a beginning for me. And there is when I started, trying some modalities and exercises for them as well. And I must say, ma'am, they have been very good. And later on, they appointed one of my PG as a physio in their team. So I feel we should expand. There is no scope for expansion. Yes.
Here I would like to ask Miti, are you dealing with women in sports in your clinics?
We certainly
so.
are indeed. So, hello, hi, can you hear me?
Yes.
Yes, we do deal with sports as well. So in terms of sort of, you know, male and female pelvic floor, and in athletes as well. So we do deal with dysfunction in them.
How successful is it?
Really successful. So in terms of if we look at the evidence in terms of what is out there in terms of numbers and
Tuesday ka felicitation. She has said, huh? I'm not there. Sorry, I also forgot.
So I think it is muted.
I said after the
Sorry, ma'am, Nilima ma'am, I guess your speaker is on. I think
Yeah.
Dr. Miti was
Yeah.
speaking. Yeah.
Yes, Miti, you carry on.
hello, hi, can you hear me again?
So I think this women's health in sports has to be tackled. It's an absolutely virgin area. And my request is to the youngsters who are enthusiastic and those who are taking sports as a specialty should also have a particular domain in this area also. Because sports physical therapy is picking up very well in the country in the postgraduate education. But women in sports should also form a separate domain for our students, for our candidates, postgraduate candidates. Or as Nilima said earlier, we have to have a super specialty program after the post-graduation in this area.
Ma'am, I feel our syllabuses also should expand a little and get modified, including these domains, what you suggested.
Yes, we will have to take advice from Bellare madam on this and then go ahead with it. So I feel we will hand over the mic to Farheen.
Yes.
Thank you, ma'am.
Thank you so much, Bellare madam, for taking so much of your time. And
my pleasure. Because if you succeed in doing it, I think my struggle for last 10 years to push this matter ahead will be very a successful thing. I'll be very happy if you people carry it over. Because that was my dream before I retired, that women's health should come as a exclusive postgraduate education.
Yes.
Thank you.
Thank you so much. Thank you so much, Bellare ma'am. And we'll make sure to carry on your legacy and the women's health physiotherapy, super specialty. I would also like to thank our Physio TV team, Dr. Ashok Sham, Dr. Rahul Chobe for the technical support, and Dr. Sona Kolke for the coordination of the session. Lastly, I express my gratitude to our attendees who have played a vital role for making the webinar successful. Looking forward for your support in upcoming webinars as well. I, Dr. Farheen Patel, sign off for the session. Stay healthy, safe, and namaste.
Thank you.
Thank you, ma'am. Thank you for everything. Thank you, Miti, for joining us today. And
thank you for having me.
Thank you. Thank you very much.
Thanks a lot, ma'am.
Have a happy week. Yeah.
Ma'am, as always, very, very informative talk. Depth of wisdom. Yeah, thanks for sharing that.
Sona happens to be my postgraduate student. So she was with me here when she was studying her master's program, and then she was with me in Manipal as my colleague.
Yes, ma'am. I had the very good fortune of working with you, under you at many times in my life. Yeah. So it has helped broaden my perspective also about a lot of things. Thank you, ma'am.
Thank you.
Signing off. Yeah.
Signing off.
Bye. Bye, everyone.